Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everyone, welcome to Cracking Cancer. I am your host, Dr. Concannon, and today we're talking about respiratory viruses and how they may trigger dormant cancer cells from a recent publication from my colleague here. So today we're joined by Samantha Murrell and James DeGregori. And Samantha, why don't you kick us off?
Hey everyone, Samantha Murrell, patient advocate here. I have stage 4 lung cancer with a HER2 mutation. I'm happy to be here.
Thanks so much.
And I'm James DeGregori. I'm the interim director of our cancer center here at the University of Colorado. And I run a lab that studies cancer progression and initiation in the context of different sort of insults. And those insults range from aging to, as we'll talk about today, virus infections.
Yeah, and thanks so much for coming on, because your paper just came out recently and has already made a pretty big splash in the context of respiratory illnesses and how can those trigger cancer progression. Yeah. So maybe just by starting off, we could just do a one-liner of what was the punchline of the manuscript, and then we'll get into details.
So I guess the punchline is that a respiratory virus infection, so an infection of the lungs, can trigger the pretty massive expansion of cancer cells that have otherwise been pretty dormant in the lungs. And this can lead to rapid progression of the disease. We showed this not only in experimental models in mice, but also validated with the epidemiological studies in humans.
Yeah, well, that's a great one-liner. But yeah, I think I was talking to Samantha, this is serving as nightmare fuel for everyone with a cough, and they have a respiratory virus, and it's lingering for a little bit. So people are always going to be wondering, or now they're going to be wondering, oh, could this be cancer progression? And it's probably a good thing to wonder that, because you don't want to ignore the chronic cough.
So, yeah, I think that, we don't want to scare people, but we also want to recognize that knowledge is power. Yeah. And, not knowing about danger doesn't help you in the long run. And, I would say that we definitely validated it at the human level in terms of right in the beginning of the COVID pandemic, because that's when we were best able to study it in a sort of an uncomplicated way. So we could study it pre-vaccine, and we could study it early on when, at least in Europe, they had reasonable understanding of who was test positive and negative before this proliferation of at-home tests. And so that helped us, but it also meant that the conclusions are limited to what it was then a pretty new infection. And so people were pretty naive to this infection. And so we don't know if that same risk is going to occur the second or third or fourth time someone gets infected. Yeah. And that may be important because, we all know that, as we're experiencing now, this is a huge flu pandemic right now across the world. And does this mean that there's going to be, this massive increase in cancer? And I'm not sure, because most people have had the flu before, particularly if you're an older person who's had cancer. You're very likely to have the flu many times. And so perhaps actually someone who's been previously exposed to a virus will have enough sort of built up immunity that the same phenomena won't apply in a case of recurrent infections.
So is the idea that the COVID, when it first came out, was so different from the traditional coronaviruses that existed, that the body, I guess, experienced it like a new entity entirely?
Yeah, exactly. And I think there's good evidence for that, right? It really was, we did not have much previous exposure to it. There's been some speculation that the reason there were fewer deaths in China may have been because of SARS-CoV-1, which had much more of a presence there than it did in the rest of the world. It was pretty spotty in the rest of the world, but that's pretty speculative. So maybe that, and of course, that's not at the level of cancer. That's just in terms of like the number of deaths from the infections. Again, that's pure speculation, but I just say that in the sense that we don't know the implications of this virus-induced awakening to recurrent infections. We really only know it in the presence of an infection of a person that's otherwise pretty naive to the virus, meaning unexposed. And this is actually also relevant in the sense that probably your best defense against this would be getting vaccinated. Sure. Because we know that the reason these cancer cells awaken is because of this inflammatory response. And you get an inflammatory response because your body is fighting off the infection. If you're able to nip that infection in the bud early on, you really avoid a lot of that inflammatory response. So being effectively vaccinated is, in all likelihood, your best defense, really, whether you're a cancer survivor or not.
Yeah. Well, and I really appreciate that you started off with some caveats, and this is something that we talk about a lot on the podcast. And, I think people should run to those who seek the truth and run from those who claim to have found it.
Yeah.
So whenever we're making scientific observations, generally, the person who's doing the research will keep limiting the scope of what you can extrapolate out to. So you initially started off by saying, this is new let's really iron out what we truly studied and not just say all viruses, all infections, which is there's an impulse to do that. There's an impulse. It's hard to not extrapolate out to the greatest generalizable field, I suppose, that we can. But Samantha, before we kick off, what questions do you have here or to help kick us off?
Yeah, thank you again for being part of this podcast. I was so excited that you could come on to talk to us because I was fascinated by the paper. And as Kyle said, it made me spiral in my head and gave me lots of questions to ask. I guess my first one is, when you say that this potentially could happen, and this is what you saw in the research, does this apply to people that have never had cancer and it could awaken cancer cells? Does it apply to people who are stage 4 and could progress potentially from the viruses? Or is it related to people that are maybe stage 1, 2, or 3, and they're in remission and this reawakens the cells? So I'm curious if it applies to all of those categories or just maybe one in particular.
Yeah, those are great questions. And I think that, we can only state what we've studied, and it has the potential to apply across the board. I mean, we know that promoting inflammation has been shown in many other contexts to promote cancer progression at almost all stages. Now, that doesn't say that in these contexts it would necessarily do so. And there is this, what we call a double-edged sword of the immune system, where the immune system can, by being inflammatory, promote a cancer. But of course, the immune system can also trigger immune responses against the cancer that can help eliminate the cancer. And that sort of balance, may be different in one context versus another. At least in the context that we studied, we specifically found that the cancer, as it grew, was suppressing the immune response. And we hope to be able to exploit that, to be able to turn the cards on it and actually maybe turn an infection into a good thing for a cancer survivor. Actually sort of almost like a booster for your immune type response against the cancer. But there is another paper. It's now on, I think it was bioRxiv or medRxiv. It's on one of the preprint servers that actually did very similar to research that we did, but they looked at lung cancer initiation. And there they do see that lung cancer initiation is promoted by respiratory virus infections, including SARS-CoV-2. And they use both mouse models of early initiation, as well as they looked at some epidemiological data. So there is evidence that this does extend beyond simply sort of awakening of dormant metastatic cells that we had studied to an initiation model. What we also don't know is, in our laboratory studies, we were studying breast cancer, but in the epidemiological studies, we didn't limit it to breast cancer. And we know, because breast cancers were only a small fraction of that cohort, that this certainly does, that the increased death from cancer is not limited to those with breast cancer. It seemed to be much broader. We didn't really have the statistical ability to break it down into different categories of cancers, but we can say it's not limited to breast cancer.
Interesting. No, it's super interesting. And it's funny, because I'm told on probably a daily basis that the COVID vaccine could have caused my cancer, right? And ironically, it seems more and more data is now proving it's actually the COVID virus itself that could have done something over the vaccine. So people need to, I think, learn that there's a very big distinction between the two.
Yeah, no, absolutely. In fact, we have planned studies. We're going to collaborate both with university and European collaborators to address this directly, where we can, sort of similar to what we did segregating people that had a positive or negative COVID test. We're going to segregate people who had got vaccinated or didn't get vaccinated. It's can be a little harder in the US because the records aren't as good. And it should be much stronger with some of the European studies and the UK studies. But we think we actually might be able to do it with US data as well. And that I think will directly address that question in the sense that did getting vaccinated reduce your chances as a cancer survivor of progressing versus increasing those chances? And obviously we need to do the research to actually determine that outcome, but I have my own suspicions of what's going to be the case.
Interesting. I'm curious why it's lungs in particular that show progression.
Yeah, no, I mean, when we did the studies in our mouse model, we only saw the progression in the lungs. In the mouse model, both the influenza, the flu model, and the COVID model are very localized to the lungs in terms of the inflammation that's caused. Mm-hmm. So that may have explained why we only saw it within the lungs. And that's probably going to still be the case even in the human population because that's where most of the inflammation is. But I will note that SARS-CoV-2 infection can be more widespread in terms of the inflammation it causes. It can cause gut inflammation, even brain inflammation. So we may start to see from the epidemiological data that it can extend beyond the lungs. We focused on the lungs because it was sort of, okay, it's a virus that infects the lungs. It was sort of the obvious first target. But I think we need to be a little bit more broad when we look into this.
When I imagine too, the lungs are a big sponge and they get 100% of your blood flow. Yeah. Everything has to go through the lungs. So the likelihood that a small metastatic deposit is going to land somewhere is higher in the lungs because it gets all the blood flow. Yeah.
It's a major metastatic site. Of course, so is the liver for a very similar reason. Bone marrow is a big site, and even brain is a pretty big site of metastasis. When we did the mouse models, we specifically looked at the liver and bone marrow as additional sites, and we didn't see any sort of outgrowth there. But again, those mouse models really show localized infection of the lungs. And so we need to broaden this to see whether you could get awakening in other sites like the bone marrow in a model that gives more systemic inflammation.
Yeah, and I love that distinction because there's a big concern about systemic inflammation, chronic inflammation, and to separate that out from short-term, acute, immediate inflammation in a localized area. It seems like the signals you were seeing were really from the localized inflammation in the lung. And I just bring that distinction up because I think a lot of people right now hear these terms of this promotes chronic inflammation. These foods promote chronic inflammation. And I don't really know what that means.
Yeah. And this is definitely, in fact, that's what was sort of surprising to us because this is very much not chronic inflammation. It's acute inflammation. When you get a viral infection, you get just massive inflammation in the lungs, for example, and it's pretty much resolved within 10 days. There can be some lingering spots of sort of almost like little lymph node-like structures left in the lungs, but it's mostly pretty, your inflammatory cytokine levels just return to baseline by day 10. So, and that's whether you're a mouse or a human. And so it's very acute, and yet it's acute, but it's dramatic. And I think that's what caused this big awakening, and also causes the big increase in risk. For example, other models have shown that old age can promote awakening of these cells. That's a more bona fide model of chronic inflammation. Sure. Just this very low level of inflammation that's over a long period of time. And if you look at the extent of awakening at any given point, it's a relatively modest increase. But I imagine over time that risk accumulates because that's an extent of awakening will happen over years.
Yeah.
So it's different kind of levels of different types of inflammation, but in the end, they can all lead to some increase in risk.
And do you think the major difference between, at least in your data, showing that an exposure to a new virus versus a re-exposure to a virus you've already seen, is the difference the extent of inflammation that elicits?
It might well be. It also might be whether you have immunity already, right? So, what we found is that the awakened cancer cells could suppress the immune response against them. And right now we're trying to understand, can we basically perturb that? And there's two ways to perturb that. One would be such if you had either prior exposure or a vaccination, which in some ways is a prior exposure, just, with like, inactivated virus, right? And because that can do two things. One, it can prevent as much inflammation. So you may prevent as much expansion of the cancer cells. If the cancer cells are required for the immune suppression, then having less of them should give you less immune suppression because it's going to be sort of a bulk action. And at the same time, having an immune system that is sort of primed to be active because it was, had a previous exposure to that same virus might provide some bystander immunity that could help eliminate the cancer cells. So this is something we're testing. And the second part is a bit pie in the sky. I do think simply by preventing the inflammation, you're going to do a lot by there. But could you actually turn what is a suppressed immune system into an active immune system to help eliminate the cancer?
Sure. Well, it's interesting you mentioned that distinction because and the bystander effect, because in my mind, that's the first thing I would assume, and this is why we do the studies, is that if you have a large amount of not necessarily specific inflammation, you have a viral infection and the immune system kind of it gets amped up, so to speak.
Yeah.
I would think you would have bystander killing of the cancer cells. So it's interesting. Your data suggests the opposite.
Yeah. And that is the hope, but we think that's more likely in a case where you can get specific T cell responses more quickly. When you get the flu, when you get a virus for the first time, like for example, in a mouse model, which is completely naive, that mouse doesn't need its adaptive immune cells, the T's and B cells that normally make the antibodies and it can specifically recognize virus-infected cells. It doesn't need those cells at all to clear the virus. It's kind of surprising. What it needs those cells for is to establish immunity for the next time it sees the virus. And so the first exposure there's a pretty long delay in the generation of that adaptive immunity, that immunity that's specific to the virus.
Sure.
And so we think that may be the difference between that first infection and subsequent infections.
I see. So it's have you developed resistance to it yet?
Yeah.
Through your immunity, the same thing you would use with the vaccine, or are you using the different element of the immune system?
Yeah.
That specifically targets new things.
Exactly. And the real question is going to be, what about partial immunity? Because as we know, vaccines don't provide perfect protection. I mean, I got the flu vaccine and I still got the flu.
Yeah.
Now, the idea is I had a pretty mild flu. And, from my own personal experience, I can't say that I had a mild flu because I got the vaccine. But on a population level, you can make that conclusion that getting vaccinated either prevents you from getting the virus infection or makes it more mild. And I think it's those partial protections that are going to be the more interesting ones to understand, because you're still getting infected and you still have an inflammatory response. But will that ability to generate some immunity actually be a game changer when it comes to whether or not you're stimulating the growth of the cancer cells or actually hopefully promoting anti-tumor immunity?
Yeah, it's a really interesting question because people have made that argument where I got the vaccine, I still got it, so the vaccine was pointless.
Right.
But if we can tie a link to, well, actually the vaccine dampened the degree of, your immune response, pushed it over to this adaptive immune response, and actually lowered your risk of developing a cancer after.
Right. So that would be a pretty powerful argument to get vaccinated. I mean, I think in some ways you're right. It's harder to appreciate for example, with the COVID vaccine, it became pretty clear that after a while, the COVID vaccine, particularly for later variants, did not prevent infection. In fact, it didn't prevent the spread. What it did prevent is hospitalizations. Yeah. And that's where the data was most clear, because you could simply ask, okay, what fraction of the population got vaccinated? Let's say it was 50%. I don't remember exactly what it was. And you looked at, of hospitalized cases, 80% or 85% were in the unvaccinated. So it could clearly show that getting vaccinated was reducing your chance of ending up in the hospital. So disease severity. But again, on an individual basis, you couldn't make that claim. And all someone had to do is point to someone who got vaccinated and still died of COVID. Of course, there were such cases. But that's not the way we look at these data. We can't. In fact, I always get asked, I get an email from someone who said, I developed metastatic cancer, in 2022, and I had gotten COVID. Did COVID cause my cancer? Of course, I can't answer that question. Yeah. I can't answer that question for this particular individual. We can just say things at the population level.
Sure.
So I'm curious, on the vaccine side of things, you're saying you have less of an inflammatory response if you get the virus itself. There are people out there, I don't know how rare it is, but I am one of those rare people that has a crazy response to vaccines. I get a flu vaccine, I'm sick for like a week, like very sick. COVID vaccine took me out for 3 weeks. I was that ill. And so I'm curious how surely my reaction to those vaccines is still causing a massive inflammatory response given that I'm get so sick, or is that not necessarily the case?
Yeah, that's a tougher question, and that's not directly within my area of expertise,
Oh, good.
but I do know that yeah, responses to vaccines and even responses to infection can be wildly variable. Even before
Mm-hmm.
the vaccine, you could have two 65-year-olds who otherwise, similar smoking history, similar everything, and one of them could have a very mild case of COVID, and the other person would be, to the point of even dying of COVID. And they did some studies that showed there were differences in people's sort of the genetic encoding of their what's called an interferon response, that could help determine it, and probably some role for sort of a more inflammatory reaction. And so there's probably some genetic predisposition, but like everything else, is a mix of all kinds of things. And I've known others like you as well. I mean, I actually tend to have incredibly mild responses to these vaccines. It's like I'm always wondering, did I really get the vaccine?
Right, right.
And yet I know other people who, like you, just get very serious responses. Other people, we can't deny vaccines, like any medical intervention, they do come with risk. And there were people that got myocarditis and some other effects of the vaccine. Often these were lower risk manifestations of what naturally COVID would do. And so it was, so we can't rule out that there might be some increased risk of even cancer reemergence from the vaccine. But I would argue that having a lesser chance of getting infected is going to outweigh that risk.
Gotcha.
Just
Okay.
like it has been, even the polio vaccine had some incredibly small risk of actually causing polio. But compared to the risk before of getting polio and getting the manifestations of polio, it was no comparison. That was a very long-winded answer to your question.
No, it's super helpful. I think because some people do have these reactions. I know a handful, right? And so they're nervous about getting those vaccines. Is it going to awaken cancer cells that way? So just trying to educate that maybe it's better to get a vaccine than actually get the virus, I think is a crucial message. I'm curious, and I understand this wasn't part of your research, but if you kind of think or believe that there might be other viruses that could do the same thing beyond just COVID and the flu, like an E. coli incident, or I don't know, I'm thinking of these larger infections that cause like an inflammatory response in your body, if you think it extends beyond the respiratory realm.
Yeah, we wouldn't be surprised. In fact, we're studying it right now. So we are starting to model exactly those things, like bacterial pneumonitis, for example, is an obvious one. We're starting in the lungs because we know the lungs, but we're going to eventually extend to, for example, a virus that might cause inflammation in the liver. Would that one awaken the cancer cells in the liver, but maybe not the lungs? So we want to extend these further. It's going to be a little harder for some of those diseases for the epidemiology. Because, for a lot of epidemiology, it's a numbers game. And you start off with big numbers and you think you've got a lot of people. And then you say, okay, now we just want the people that had previous cancer. And that's a much smaller number. And then you have to have those that you have follow up on. So I think we could easily do those studies. Well, not easily. We can do those studies in animal models. They're going to be a lot harder to pursue epidemiologically. COVID really provided a unique opportunity in that we had massive numbers of people infected. And at least in countries like the UK, they had very good follow-up on these individuals. So we were able to do this sort of study.
Following up on that and speaking to the epidemiologic terms, we can get a little bit to maybe how likely is it the incidence of a new respiratory viral infection, for example, COVID, leading to an awakening event or an increase of cancer, like how concerned should people be?
I mean, I think that, you don't want to live your life worried about something, but if I was a cancer survivor, I would take sort of the necessary precautions, right? I would try to avoid respiratory virus infections. And I think that, it might be someone, such as yourself, where vaccines are very tough to tolerate. Well, maybe that's going to change your calculus on that. Yeah. So I think everyone's got to come to their own decision on how to best accomplish that. When flu is rampant, I mean, I know there's someone in my lab who's very sensitive to respiratory virus infections and decides to, wear a mask when they know that the virus is all over the place. So right now with the flu, this person's wearing a mask in my lab, and that's totally fine because that person's decided that, okay, I'm going to lower my risk a little bit. And that's the way that they're doing it.
Sure. Well, and I like the distinction of you're armed with this knowledge, and then it might change what you do. And for the question of awakening dormant cancer cells, there's a lot of patients who, we see as oncologists who have had a history of a cancer. And usually the way it goes is we'll monitor them pretty closely, after that initial treatment. And if we think they're either cured from a localized cancer or the disease is under really, really good control and it had spread, maybe they got an immunotherapy or something like that tends to lead to longer term outcomes, we'll space out the scanning interval. Mm-hmm. So if someone gets a viral infection and that lingers a little bit longer than you'd think, it may be 4 or 5 months until we would scan them again, or longer, but we'll do it sooner if those symptoms are atypical, concerning for something.
Right. No, I think that's a perfect example. Is it may mean closer surveillance of someone after they've had such an infection. And I think we do need more data to sort of say what is the extent of that. Certainly, I think our data would strongly suggest that should be the case with a new virus like COVID was, the SARS-CoV-2. But I think, how much that extends the virus will require more research. But it can't hurt, right? Yeah. Doing a scan can't hurt. I think when you start getting more, invasive with the protocols, then you got to start thinking of the pros and the cons of a further intervention.
Well, nowadays we're developing these peripheral blood tests that can look for the cancer that you had before. So if it's an awakening of a pre-existing cancer, we can at some point develop protocols to look for that with a blood draw. Hopefully.
Yeah. No, exactly. There are very good methods to do that. Now, I don't know if they're FDA approved, but they are good. Yeah. Because that I think would be a powerful method that's really pretty non-invasive that one could monitor. And then you could see and that actually would provide powerful evidence in sort of the breadth of this phenomena, right? Mm-hmm. If you followed in people that had different infections who were cancer survivors and were being monitored, as you said, and you followed them afterwards in their blood, you could actually see, is there sort of a consistent awakening in which virus infections or bacterial infections do this and so forth.
Yeah. I mean, the technology we're integrating it in clinics more readily now. They take the primary tumor, they sequence the primary tumor, and they find the tumor-specific mutations, and then they could sequence the blood really deeply. It's rare that we get false positives, but occasionally you do. But I could see that being a modality where you could study this, and it's not terribly expensive. But
that would be pretty powerful.
Yeah.
I know I get one of those tests done, and it's been very anxiety ridden to watch it, but it's also very helpful for insights, right? But my oncologist also tracks I'm going to butcher the word, but some kind of protein that's like an inflammatory marker, very basic. And then CA125, which is kind of inflammatory marker as well. And it's interesting because when I don't get sick very often, but when I do, those markers will spike, kind of showing that inflammation, right? But the tissue one that I get, that's very specific to me doesn't change. So it's reassuring to see not having that change in that very specific tissue one when I know that my body is inflamed, because I always worry. And again, I haven't had COVID or the flu since my diagnosis, but I always worry inflammation equals rumblings and what's going on. Yeah. It's very scary as a stage 4 patient to see those inflammatory markers. But I will say that even from I exercise a lot, and from excessive exercise, those inflammation markers also go up, which I find super interesting. And then I'm like, okay, well, was I exercising too much? Is this not good? Is this going to make my cancer worse by exercising? So I think there's a misunderstanding out there about, and maybe you can talk a little bit about this, about inflammation not necessarily being a super bad thing in all cases, because I think people sometimes are nervous about exercise, and are they causing inflammation that's going to progress their cancer?
Yeah, no, I mean, there's clearly good inflammation and there's bad inflammation. And I mean, the evidence is overwhelming. Exercise is good for you. Now, there are limits. The sort of extreme athletes, there was a recent study that showed that, I don't know if it's people that run the centuries or, the 100-mile runs. It was the really extreme runners.
David Goggins out there.
Yeah, they had increased risk of colon cancer, pretty substantial.
I saw that.
But I think it's like, if you're doing something reasonable, which I always consider sort of marathon and below, although now I've kind of come to the conclusion that even a marathon's a little bit extreme, having done it a few times. And I'm like, I wasn't really enjoying it by the last few miles. I'm not sure that's just my own personal opinion, but that I think the evidence in even there's actually been some recent evidence. I don't know if it's published, but it was at ASCO, where in people undergoing treatment, exercise substantially improved outcomes. And I think that was probably all within the realm of normal amounts of exercise. But by normal, I mean, it's probably still going to be at, the top 15% of what Americans tend to do. So yes, exercise causes some inflammation, but I think in some ways that's sort of preparing your body to better sort of deal with other inflammatory events. And so that low level of inflammation is not the same thing as sort of what we would consider chronic inflammation. It's during the exercise. And I think in the end, can't explain why it's a good thing, but I think the overwhelming evidence is that at least the exercise into itself is a good thing, both for preventing cancers and for improving outcomes for patients under treatment for cancer.
Yeah, and I like how you made that distinction between essentially inflammation that starts and goes away versus inflammation that starts and doesn't go away.
Yeah.
And I mean, some of the research we've conducted in my groups around smoking too, is that inflammation that starts and doesn't go away. And we've seen the signals that can lead to the bad inflammation that suppresses how something might deal with a cancer or.
I mean, every time you get a wound, that's inflammation that's going to resolve because you resolved that wound. Yeah. And, I think I think it was it over 100 years ago that the phrase was termed that cancers are wounds that never heal. I forgot who coined that. I don't think it was Paget. I think it was actually 50, 60 years ago. Anyway, I don't remember who coined it, but we often refer to cancer as a wound that never heals because it is that sort of chronic inflammation that won't go away. And in some ways, it also probably leads to the immune suppression because at some point, the immune system is going to be, hey, we got to back off this thing or we're going to cause more damage than is worthwhile. And so the immune system even becomes sort of tolerized to whatever's going on at that point.
Yeah, I mean, it's funny you bring that up. And I don't know, Samantha, I think you've sent me this stuff about the misinformation out there about the cancers being the body's attempt to heal itself, and therefore you shouldn't intervene. Has somehow gained traction for the people who are pro-cancer in the cancer fight. But yeah, that's been you hit a nerve there.
Yeah. No, I mean, of course, ideas are ideas, but in the end, empirical evidence is what counts. And obviously, if you don't treat a cancer, you're going to die of that cancer. I mean, there are rare exceptions, of cancers that spontaneously go into remission or even, go away. And those are wonderful to try to understand, but they're the exceptions, not the rules.
Yeah. And one thing I want to get into is, what was it about it, maybe a little more specifically about the viral infection, that does awaken the cancer?
Yeah.
Like, did, is it something they're secreting? Is it the virus getting infected in the cancer cell itself?
Yeah, no, we worked that out in the sense that what we show is that if the mouse lacked this one cytokine, it's a molecule that communicates the inflammatory response. And it's normally part of the way you deal with any pathogen. There's signaling, the body sends out alert signals and says, hey, we're getting infected, we need to do something about this. And so we looked at one of those molecules that's been known to be also a cancer promoter, and it's called interleukin 6, also known as IL-6. And so we used mice that didn't make IL-6, and we could show that they could still respond to the virus and clear the virus. It's actually been shown before that if you gave higher doses of the virus, they wouldn't be able to respond as well. So it still is part of the normal sort of response to eliminate the virus. But we showed that if we didn't have that, then the cancer cells did not awaken and did not expand nearly to the same extent. So it greatly dampened the cancer cells' expansion. And that cytokine, the IL-6, comes up rapidly after infection. It's actually made by the infected epithelial cells. So the cells in your lungs that get infected with the virus start making IL-6 and to alert the community, basically. And that IL-6 can normally stimulate like macrophages and other cells to promote an inflammatory response. But they also go to these dormant cancer cells and can directly awaken them. Yeah, and so we're now pursuing, the potential that modulating that pathway. And the timing here is going to be important because you don't want to prevent an effective immune response, but maybe modulating that pathway could be an effective mechanism to limit the risk for a cancer survivor who gets infected. And the reason we think that's possible is because actually blocking IL-6 and blocking its pathway are FDA approved for people with COVID, but people that have severe COVID. So they end up in the hospital, for example. And the question is, could we extend this to other people who get COVID, perhaps, targeting those that are cancer survivors?
Yeah, it's a really interesting thought, because the targeting IL-6 and just the idea of immune suppression is something we use a lot to treat respiratory viruses.
Right.
Because, people think it's usually the virus that's causing all the damage, but most of the time it's your body's reaction to the virus. And if you dampen that, you can minimize the damage and your body will eventually clear.
Yeah. It's interesting. Almost all approved treatments for COVID were actually suppressing your response to it.
Yeah. Yeah.
Which is kind of ironic, right? But it's our excessive response to it.
Right. Yeah. That's a good way to put it.
Yeah.
But it's interesting if in that, in the same brushstroke, that's the mechanism by which you could reduce the risk of a cancer emerging.
Right. So it could actually be something that could be win-win. And we think the same thing should be the case. We have to test it for vaccines, in that what you don't want is, you never want a preventative that comes along with increased risk, because then you may be preventing an emergence of a cancer, let's say, and I'm just randomly throwing out this number, in 4 out of 100 people. But at the same time, if you've increased the risk of something else from happening by even just 4%, well, you're going to completely counter the benefit you did with the increased risk. But if you have something like a vaccine that reduces your risk of getting the infection to begin with, so it would have been recommended anyway, independent of this, and at the same time has this added bonus that it's going to decrease the rate of, either based on this other study, of new lung cancers or new cancers, or of cancer reoccurrence, it's a win-win. And so I think we need to look for win-wins.
Well, and I want to add on, or ask additional follow-up here about the concept of dormant cancer cells, which is a scary concept. But, as an oncologist, I think we probably have quite a bit of dormant cancer cells, or at least the cells that have the potential to become cancerous.
Yeah.
So could you define what you meant by that in your work?
So for a number of cancers, and breast cancer is one of them, you can get the disease and you can be ostensibly cured of it. There's no detectable disease, whether by surgery or by other treatments. And with every given year after that, and this is particularly the case for hormone-positive breast cancers, is there's always some risk of relapse. And that risk can go for 20 plus years. I don't know if you if you all remember that a few years ago, Olivia Newton-John died of breast cancer. That was a breast cancer she had had 20 years before. And so those cells seem to be essentially lying dormant. There's some thoughts is that they're in sort of a balance with the immune system. So any growth is balanced by attrition from the immune system. But probably, I think the better evidence is that they're relatively, the immune system is relatively blind to these cells. So it just ignores the cells. And at the same time, these cells are quite quiescent. They just sit there. They don't divide. They're just not doing much. And I think for most people that have had a cancer that goes into such a remission, particularly for breast cancers, because while there is that chance with every year that you will get a remission, still, I don't know if it's the majority, but a good number of women who get ostensibly, cured of their breast cancer will live the rest of their lives without getting breast cancer. So the question is, do they not have dormant cells, or do they just have dormant cells that never woke? And I would actually favor the latter, is that that almost everyone's got the dormant cells. Just for whatever reason, they don't wake up for a fair number of people. And so in some ways, we almost want to think, how do we keep those cells asleep?
Yeah.
Because, we're all going to die at some point. So maybe if we could make it so that we die of something else and those dormant cells die with us instead of dying of their reawakening, that would be sort of the overall goal.
Sure. Well, I can already see the clips of all of us have dormant cancer cells is going to add to the nightmare fuel that this episode. But I mean, our evidence, we have good evidence in population statistics and prostate cancers. The example I usually give is that most men, once they reach a certain age, are more likely to die with prostate cancer than without it.
Exactly. Yeah. We, in some ways, all guys want to live to the age where they have a prostate cancer, even if it's just sitting there. And, the same thing with thyroid carcinomas. We end up with this, our bodies, as we get older, end up with a large number of pretty advanced malignant cells, if you look at them sort of genetically. And yet we've evolved over time ways to keep those in check. And fortunately, the ways to keep them in check often win. Certainly on a per malignancy standpoint, they almost always win. And so what we need to understand is we need to understand those normal mechanisms where we don't get cancer. And why are those so effective? Why is it that most men won't develop an aggressive prostate cancer by the time they die, even if they live to 90? And that it's the exception, not the rule, that they get a lethal prostate cancer. I think by understanding that, then we can start to develop strategies to try to limit the risk of these cancers as we all get older.
Yeah.
So I have a bit of a woo-woo question. So please tell me if it's too woo-woo. Vitamin D. So I have seen a lot of correlation just from talking to people that there seems to be quite a correlation between low vitamin D levels and cancer either forming or progressing. And I'm curious if you have any take on that whatsoever, understanding that's got nothing to do with your research, but we're talking about like kind of immune modulating, awakening cancer cells, things like that. So I was just curious, if you research vitamin D online, it says like it can block IL-6 or at least try and suppress it a little bit. So I was curious on your take on vitamin D, if you have any thoughts.
Yeah. Well, I'll start by saying I do not have expertise in vitamin D in particular. Yeah. That said, I mean, I think that, in terms of maintaining our overall health, being vitamin deficient in any specific vitamin is going to be a bad thing. And when your overall health declines, other stuff tends to decline with it. In other words, that sort of indicates that you're going to have less of an active immune system. You might end up being more inflammatory because damage isn't going to get repaired as well and so forth. And so, but I think we also have to be careful about, there's often data that shows vitamin deficiencies can be associated with increased disease risk. That doesn't mean that we should necessarily, we should try to then get the right amount of those vitamins, but not excessive amounts. And I think often people think, well, if, having the right amount of vitamin D is good, then I'm going to take, 10 times the RDA or even more extreme amounts of it. And that's going to be even better. And I think that's where the fallacy comes in, is that too much of a good thing can be very much of a bad thing. And
Yes.
so my recommendation always, if you want to make sure I don't take any vitamins, I don't take any supplements whatsoever, but I eat a very balanced diet. I eat plenty of fruits and vegetables. I try to live my life in moderation in every way possible. And, that includes, even drinking and other things like that. I just try to limit the bad stuff and try to get as much of the good stuff without, being to the point that, I'm a horrible dinner guest. Right? I like the phrase that I once heard is that everything in moderation, including moderation. But so the bottom line is, I think that, yes, you do want to avoid an unbalanced diet or an imbalance in any particular vitamin. But at the same time, you also want to avoid excessive amounts of anything in particular.
Mm-hmm. No, and I can attest to that. In fact, I for a period of time, I took so much vitamin D that I ended up having bone issues. Yeah. So I do not recommend whatsoever. But I also say, I think I'm a prime example of I was so over the top with my health. To the point it was like an OCD forming habit of making sure I was healthy in all aspects, in quotes, healthy. And I still got stage 4 lung cancer. Yeah. So I think the moral of the story, and very much my mom and I both are just like everything in moderation. Yeah. Because you can, this can happen to anyone. Yeah. So don't restrict your life. I think I've learned that the hard way.
Yeah. But of course, I mean, as we were talking about sort of population level statistics and individual, and, someone like yourself, who was doing everything right, and non-smokers, and, we know many cases of non-smokers who get lung cancer, for example, and it seems just supremely unfair. And in some ways it is. But what we do know is that smoking increases, for example, your risk of lung cancer on the order of 10-fold, right? But that's a 10-fold risk. That doesn't mean it's zero for the non-smokers. And aging increases your risk of lung cancers and pretty much all cancers. But that doesn't mean it's zero for someone who's 30 to 40 or something, at a younger age. It just means it's substantially less. But that still means that there are people that are in those categories where they should be very low risk. Some of those people will still get it, even if their risk was 100-fold lower than that 65-year-old had been smoking a pack a day for their whole life. And so it's sort of the unluck of the cards in some ways. And so, I'm very sorry that you ended up on the, wrong end of that. But you seem to be dealing with it in a sort of very positive way, and that you're trying to help others who have the disease. And I think that's very admirable.
Thank you. Appreciate that. Yeah, trying to just spread awareness that anyone can get cancer at any time, and just to be wary of that, I think, is a critical education component, because I really thought I was immune. Very much not the case.
Yeah, no, exactly. I mean, we can lower risk, but lowering risk does not mean zero risk.
Right.
And so you always have to be prepared. At the same time that one doesn't live their life with such an obsession that you're not enjoying life. I always think about the people that want to extend their lifespan, and they do everything they can to extend their lifespan, including like with caloric restriction and all these things. And I'm thinking, okay, they're spending 20% of their day weighing out their food and doing everything perfect in order the hopes of living 15% longer. And there's no evidence they're going to live 15% longer. But in the meantime, 20% of their life is miserable. So that's not exactly a sort of a good strategy either.
We spoke about this before, Samantha. We were preparing an episode that we should do at some point about evidence that came out showing that hypothermia can decrease cancer risk, improve cancer outcomes, and it was a mouse model based system. And the degree of hypothermia that these mice lived in had to promote essentially shivering. Yeah. And they had to live that way. Yeah. So it's like, okay, well, in theory, you could see that, this type of fat tissue becomes active and it causes this. And the takeaway that was being, I'd say, extrapolated out of the patient community is let's do cold plunging. Yeah. And it's like, fair enough, but you may have to live in the cold plunge to get the benefit of these. And frankly, I would just not. Yeah. So it's tough. And this is one of the great things about you coming on is I think people take elements of what we've studied and we're confident in.
Yeah.
And they extrapolate it out to apply it to their lives in ways that don't necessarily help them, but do potentially harm them.
Yeah.
And I think your example of, maybe the reasonable risk mitigation tool is a vaccination.
Yeah.
Or if you're in a really high risk season, lower your risk a little bit, maybe use a mask.
Yeah.
But do you have to quarantine in your home for the rest of your life?
Exactly.
Probably not.
Right. Yeah. Everything in life has to be a balance, and one needs to make their own decisions about risk and, what risk is tolerable. I mean, for example, we've learned that at least what they say is any level of alcohol increases cancer risk. But does that not mean that I'm not going to have a beer on Friday night? No, I'm going to still have that beer.
On a podcast?
Right. Exactly. So I think that, one has to make a decision, a sort of what is the level of risk that someone can tolerate and what should one do to mitigate that risk and still enjoy life. Right. And, but I think like for the example, that cold example is a good example where that doesn't mean we can't learn from the research. That maybe tells us something that could lead to an intervention that is maybe cold mimicking that doesn't require you being cold.
Yeah.
It's taking the good parts of it and avoiding the parts that are miserable.
Yeah. Yeah. Same with how do we leverage, anti-IL-6 or, how do we leverage these things and then not have to live in a bubble.
Yeah, exactly.
But I think people in the cancer advocacy community and the patient community now are a lot more informed than they were before. And I think with this has been a bit of a double-edged sword where they don't have as much training extrapolating this out, or since they haven't run the studies themselves, it's harder to see where the limitations are.
Yeah.
And that's something we talk about a lot, are the limitations of mouse models and how often can we cure cancer in mice.
Yeah.
And then it goes into humans and does nothing.
Yeah. And often I think that's because the mouse models were not good.
Yeah.
And for many years, it was because we were using, this a tumor under the skin of a immune compromised mouse. It was a really very contrived model, and there are actually some, actually legal reasons for that they go way back. Yeah, basically a lot of these genetically modified mice were covered under some patent, and so companies wouldn't touch them because there was intellectual property reasons that persisted for so long. But those models were very contrived and in some ways an easy target.
Yeah.
And it was too easy to treat those models. And I think that we now have models that are much better and actually much harder to cure from, even to treat effectively. So I'm hoping that the ability of these models to be predictive is going to increase as we move forward, not decrease.
Yeah.
But we also have to recognize mice are not humans. And that's one of the reasons we really paired our study with epidemiological data, because we really wanted to know, before we scare people with the data in mice, do we see this within the human population? And the answer turned out to be pretty clearly yes.
Well, and I'm not sure people appreciate how hard that is to do.
Mm-hmm.
The mouse models are hard enough, but getting the epidemiologic data and accurately obtaining, curating that, making sure it's clean, it's correct.
Yeah.
The amount of data you need and just the rigor of going through, in my experience of that kind of data, is just mind-numbing spreadsheets.
Yeah.
People think research is exciting.
Yeah.
It doesn't have to be. I think that it was published in Science, a really high impact, a really big publication, and rightfully so, because it is just so hard to do that.
Yeah. You mean our paper was in Nature?
Nature, sorry.
Yeah, it's okay.
The Science.
But I mean, that was really hats off to our collaborators. We had collaborators both here on campus, like Jun Xiaohu and Desheng Gao, but we also had really critical collaborators at the UK and the Netherlands. Mark Shadow-Hayam and Raoul Vermeulen, and we couldn't have done it. I mean, my lab would not have had the expertise to go through those data and to do those sorts of analyses. Like you said, they're not trivial, and particularly with massive databases like the UK Biobank.
Well, and another thing that we get into frequently on this podcast is that correlation, meaning, for example, if low vitamin D is associated with worse outcomes, it doesn't mean that low vitamin D causes worse outcomes. Mm-hmm. It could be that something causes both. Maybe you're inside on the couch all day, and that makes, you're not going to cancer treatments. You also have low vitamin D. The best example I have of this is that an early study came out, and you you probably remember the details about this more if you were in the field at the time, but coffee consumption led to cancer increased risk, lung cancer.
Yeah.
And it turned out that people who drank coffee were more likely to smoke more. But that wasn't part of
they didn't
data.
control for that, right?
Yeah. So they only saw increased coffee leads to increased or is associated with increased cancer, and they made a conclusion that they're linked. So to take large data sets and rigorously detangle that to make good assumptions based on correlative data, it can be done, but it's not easy.
Yeah. And I think one of the things, one of the reasons we went with, people like both here and in the UK and in the Netherlands, they were top experts in the field in this. And so they really know how to control for what we call confounding factors, which is exactly that. Just someone's age. Do they smoke? What kind of cancer did they have? What stage cancer did they have? All those variables that could determine outcome that needed to be controlled for. And that's another reason that you have to start off with such big numbers is because in order to control for those things, your numbers start shrinking because I can't use these people because we don't have appropriate control in the other group and so forth. But yeah, so I think that, and that was actually the other power of having both experimental and epidemiological. Just the experimental says only in the experimental can we make these conclusions. Just the epidemiological says that there's a correlation between these two. But by putting the two together, we can much more sort of confidently claim that there's a cause and effect relationship.
And James, if you were to leave our guests with one statement or take away from your manuscript, what would it be?
That, I think there's always room for understanding more, that we don't know everything yet. But I think we can say at this point that there are risks associated with new virus infections that we need to be aware of. And so I think our next challenge is going to be, how do we leverage that understanding and how do we gain more understanding to be able to develop, preventatives and interventions that can lower these risks and maybe even turn this into a good thing, where an infection can be used to actually promote elimination of a cancer as opposed to outgrowth of the cancer.
That would be a heck of a find.
Yeah. And thanks so much for interviewing me. And thank you, Samantha, and best of luck with your dealing with your cancer and everything moving forward.
Thank you. Appreciate it. Thank you for your time.
All right. Thanks, James.
Sure. Thank you.
Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.